The deep dive. Today, we're really getting into something important: alcohol use disorder. Think of this as a kind of masterclass. It's a significant health challenge affecting so many people. Our goal here is to cut through the complex medical stuff and, give you the key insights you really need.
That's right. And what we're drawing on today comes straight from clinical insights and management texts. It's about building a solid foundation, understanding what alcohol actually does to the body and mind.
Okay, good. So let's start right at the beginning. The basics. What actually is a standard drink?
Well, the sources define it pretty clearly. 10 milliliters of absolute alcohol, that's about 7.8 grams.
Right. 10 milliliters or 7.8 grams. And having that standard measure is important. Yeah.
Oh, absolutely. It gives us a consistent baseline to talk about intake and then how the body handles it. Well, about 90% gets metabolized, broken down in the liver.
In the liver. Okay. And that happens at a set rate.
Roughly, yes. Around 8 grams per hour. It's fairly constant for most people.
Interesting. So it's not just about how much you drink, but also how your body processes it over time.
Exactly. And here's where it gets even more fascinating, perception-wise. There's something called the Mellanby effect.
Mellanby effect. Okay, what's that?
It means you can actually feel more intoxicated when your blood alcohol level is going up
More intoxicated when it's rising.
than when it's at the exact same level but falling. So you might feel okay as it drops, but then another drink hits harder than expected.
Ah, I see. That sounds like a way people could easily misjudge how impaired they actually are.
Definitely. And then there's another phenomenon, reverse tolerance, sometimes called sensitization.
Reverse tolerance. So you need less alcohol.
Kind of, yeah.
Yeah.
With chronic use, especially if there's liver damage, smaller amounts of alcohol can actually cause greater intoxication. The body's response changes over time.
Wow, okay. Let's shift gears a bit to the more immediate acute impacts. Alcoholic blackouts, what are those exactly?
They're a form of anterograde amnesia. Basically, the brain temporarily stops forming new memories.
So you can seem fine talking, moving around, but not remember it later.
Precisely. The sources give us a mnemonic, AAGH, which helps remember features like amnesia, appearing in control, maybe fear of hurting someone, memory formation, just pauses.
AAGH.
Yeah.
Got it. That's quite striking. And linking this to withdrawal, it can get much more serious, right?
Very serious. We're talking about delirium tremens or DTs. This is a full-blown medical emergency.
And when does that typically happen?
Usually kicks in around 72 hours after someone stops drinking heavily. It's intense. Think severe confusion, visual hallucinations often.
Hallucinations? Okay.
Yeah, and major autonomic hyperactivity. So uncontrollable shaking, racing heart, sweating buckets, what we call diaphoresis. It needs urgent medical management.
Okay, so those are the immediate dangers. What about the long haul? Chronic use.
That leads us to really serious neurological conditions. Two
Mhm.
key ones are Wernicke's encephalopathy and Korsakoff psychosis.
Right. Wernicke's and Korsakoff. Let's break those down.
Okay. Wernicke's is usually acute. The mnemonic coat helps. Confusion, ophthalmoplegia, that's eye movement problems, ataxia, which is poor coordination, and it's all linked to thiamine deficiency.
Confusion, ophthalmoplegia, ataxia, thiamine deficiency. Is it treatable?
Yes, potentially reversible if you catch it early and treat with thiamine. That's the good news.
And Korsakoff.
Korsakoff psychosis often follows untreated Wernicke's. Think RACK. Rarely reversible, profound anterograde amnesia, trouble making new memories, often worse than forgetting old ones, and it's chronic.
CAR-ACK. Rarely reversible. Anterograde amnesia, chronic. So much harder to deal with.
Much harder. And here's absolutely a critical point from the clinical texts. You must give thiamine before you give dextrose, like a sugar 4V.
Thiamine first, then dextrose. Why is that so important?
Because giving dextrose first can actually precipitate or worsen the brain damage in someone who is thiamine deficient. It can cause irreversible harm. It's a vital rule in emergency medicine.
Wow. Okay, that's incredibly important to know. So how do we even start identifying if someone might have an issue?
Well, there are screening tools. A really common one is the CAGE questionnaire. It's quick, just 4 questions.
CAGE. What does that stand for?
It asks if you've ever felt you should cut down. Cut down if people have annoyed you by criticizing your drinking, if you felt guilty, or if you've needed an eye-opener, a drink first thing in the morning.
Cut down, annoyed, guilty, eye-opener. Simple, but seems like it could be quite telling.
It is. And if an issue is identified, then we look at management. For detoxification, calming the nervous system during withdrawal, Benzodiazepines are often the first choice. Drugs like chlordiazepoxide or lorazepam.
Right, to manage those dangerous withdrawal symptoms like the DTs we talked about.
Exactly. Then for longer-term maintenance, there are different approaches. You've got deterrent agents like disulfiram.
That's the one that makes you really ill if you drink alcohol.
Yes, it causes a very unpleasant reaction. You have to be super careful, even about alcohol hidden in foods or, say, mouthwash.
Right. And what else?
There are also anti-craving agents like naltrexone or acamprosate. These work differently. They help reduce the urge or the craving to drink.
So options to help resist the urge itself.
Correct. And critically, medication is often just one part. Non-pharmacological approaches are vital. Think Alcoholics Anonymous, AA, and its 12-step program.
Sure.
And therapies like cognitive behavioral therapy, CBT, or motivational enhancement therapy, MET-NAT. These address the psychological and social sides.
Right, so it's a multifaceted approach, medical, psychological, social support.
Absolutely. It has to be comprehensive.
Well, this deep dive has really highlighted just how complex alcohol use disorder is. From the body's basic processing right through to severe long-term conditions and the different ways we can manage it. A real masterclass, like we said.
It really is. And maybe it leaves us and you listening with a question to think about. How can we, as the society, take these clinical insights we've discussed and apply them better to genuinely support individuals facing these challenges and also just build better public health awareness around alcohol use? It's about bridging that gap between knowing and doing.
That's a really powerful thought to end on. Moving from knowledge to action, we definitely encourage you to keep exploring these important topics.